I'm looking forward to presenting and then.
Okay, actually, I mean, probably just, I don't actually know your name.
Yeah, I'm Dan.
Dan is
First time I've been on this Thursday, the other two nights. How's everything going in here? Or consuming?
I just got here.
Oh, okay, well, lucky you.
How many times? have you
But I was in.
How's that?
That's good.
Including one.
Seemed to work well.
Mhm.
Not super hugely.
Oh, really? The one that was in earlier this year, the big one. It was pretty cool.
Unfortunately, my degree started in. It's not.
There are other presentations in the folder. And usually everybody has like a bunch of like.
Yeah. Next time.
Yeah.
It's like it's nice for them.
But I didn't feel like we got to drive every time, but.
Yeah, I want this one slideshow thing.
I'm just getting used to the conference experience.
Excuse me. Yes, would you like to transfer your PowerPoint onto the computer so you don't have to run it your USD?
It's on the desktop.
I have a lot.
I told it to the desktop.
Actually, I have a lot. Definitely not. It's just like. Oh, okay. Point of this.
I did.
Wonderful. You're all set.
Who's this for? Where's the time?
Yeah.
Yeah. I mean, if it's open, that's good.
Yeah, I was,
It's fine.
okay, I guess some people do like that. I haven't done it. But,
It's funny because it's just leading others, but like, it's in a good professional context.
I feel like it probably gets funner the later you get in your career than when you know.
If you're in attendance or you present
Present.
So I'm your timekeeper.
Great.
I'm gonna be right here in the first row. 3 minutes, 1 minute stop. I'm a senior tech person, so if you need help with anything, the PowerPoint isn't working for some reason. If the live stream is messed up for some reason, they'll text me about it. I'll let you know.
How does it work with just the 3 presentations then?
So you are gonna get a total of 20 minutes for presentation and questions.
Okay.
I believe it is 16 minutes and then 4 minutes.
Yeah.
16 and 4. If that works for both of you, probably that's what I would do. 16 and 4. If you're comfortable doing 16 presentation, and you're welcome to be short.
Yeah.
You're planning on 12.
Perfect. Great.
Thanks, y'all are so thorough.
This is much more organized than the other conference.
I have no part in their position, but yes, they're very good at it.
You're, well,
I'm executing other people's organization. I'm here to press the button before you push the part. Yeah.
Well, I feel
appreciate
like
it.
it helps that it's through the institute and the university, because then they can script all their students to do all the work.
Yeah, doesn't hurt. Yeah, there's the students who are being directed then by the separate Friday Center staff for this convention center specifically. So all of our tech is outsourced to the staff for this convention center. So like they're dealing with all the complicated stuff. And then the students just are like, hi, timekeeping.
Well, timekeeping can be really hard sometimes. People can get pretty. Well, I think like at this conference, it's very friendly, but I've seen it for some other places where people get kind of.
Weird about it.
Yeah.
I have to. Yeah. I think the worst I've ever had at any conference is someone ignore me, but it definitely people are. I've seen people give time for like nasty love that are unpleasant.
It's too bad.
I'm looking forward to your presentations and okay.
Oh, yeah.
This is from session 1. I will. Okay. Have you guys presented using this setup before? Where you have a dual monitor, like this is not going to be what's up here? Yeah. Okay. You're presenting you with notes on this screen.
Yes, I
I
had to make sure that it did that.
Yeah. Hello.
Hello.
Are you moderating?
Yes,
Fun.
you're my timekeeper.
I'm your
Okay,
timekeeper,
Good, good. That's a very good partner for today. So are you presenters?
Yes,
You are?
just.
Jesse. Hold on. You're the last one, the third one. And you are
Kelly.
Hmm?
Kelly, is
Kelly?
the first one,
Okay.
but presents is not here, so I'm actually presenting for him.
Okay.
I'm not sure
Oh,
why.
your name is here, Kelly. and
Yes.
Yeah, I am present. Okay.
Yes, so he will not be here, unfortunately.
Okay.
Just
So how do I pronounce the full name?
Kelly Endres.
Endres.
Yeah.
Okay. And Jesse Contreras. I'm Carlos.
Nice to meet you.
So today, are you? Yeah.
Ayse, that's her name.
Ayse. Okay.
And she can be right back.
Hi, Tony. How are you?
Hey, all right, how are you doing?
Fine. One question. Yesterday wasn't, I forgot which one, but the topic wasn't there. It's one of those small rooms.
Mhm.
And I sent a message about the mic that wasn't working. But that's okay. But the question is, where's the tablet?
Yeah, so the tablet should be right there.
Yeah, okay, it wasn't there. I don't know why. The one on the,
Well,
on the other side there, which the one was,
so I did say some of the,
bellflower, it wasn't there.
okay, it was there this morning, so what could have happened is that maybe one of the student volunteers kind of grabbed it and kept it with them, which I've said is fine. That way they have, they can just quick draw on the buttons whenever you need help. You don't have to come
Yeah, it's
back.
already given. That's
Okay, maybe that, because I saw this support here. No, there's a kind of support here. I don't know what was there, but there wasn't tablets there, so that's why I had
I
to.
did notice some bellflower, I believe, yesterday when I was shutting down. Somebody had put it inside the lectern,
Right.
so maybe that's what happened.
Yeah, probably.
Okay.
And when the people are speaking here, I couldn't come in.
Yeah, exactly.
It's not, it shouldn't be something that you should do, you know?
Right.
Also, I'm saying the correct thing when I say that might pick up people just talking from the audience, right?
Yes, yeah, so that little egg-shaped doohickey is what gets all of our audio into the Zoom call.
Amazing. Wonderful. Just wanted to make sure that was, I told the session earlier in this room that, and I was like,
Are you aware of the time? How much
The right
minutes?
thing.
12 minutes, 3,
Fair
4.
enough, I appreciate you checking.
And how do you prefer? Just handle the Q&A or asking to handle? Well, if I just ask questions and take the question from the audience. if you want to do that, okay.
And they'll need the microphone, right?
No, they don't
They
need.
don't need it.
No, they don't need. And she will be keeping track of that, and then when we start Q&A, she also have the 3 minutes time for her to know, okay? And if I see that's going more than that, and I may need to interrupt. but-
Test 1, 2.
That's good.
Test 1, 2. Okay, that's a little better.
So you should get out a little early then.
And do we know the order for these presentations?
I had mine pulled up first, the one with the blue inside.
Okay, do you remember what you named the file?
I think I had it pulled up.
Ercumen, UNC 2023, Contreras Water Health,
Oh, I just put, yeah.
this one?
Yeah. the bottom.
Gotcha. I don't have an issue there, Ayse.
Sweet. Okay. And you know who is second?
No, she's, I think she just dropped out, so she'll be back.
Well.
What you got?
Are we going by order in the?
Wow.
Is this the only stuff we moderated by the products or?
Every day.
Every day.
Yeah, there is.
Sorry, I found that one.
Yesterday, when the extra hygiene.
Oh, interesting.
Yeah, no, I learned a lot. I have a 11-year-old daughter, so. Yeah. And I'm scared because things everybody now.
Yeah. There's just 3. They wrote.
So I learned a lot, yeah.
So I'm not sure what that is.
Okay, maybe that was from earlier
So
today.
do you
Yeah.
work at the water?
I'm a PhD student here,
Oh, okay.
Thank you very much.
and I'm speaking to our institute, they're sponsoring.
Do you know, like 20 minutes total?
Yeah, the water.
Every day. Do you know how much that
Really
is?
cool.
64?
That's like.
Come over here.
So,
Forget, don't have.
Yeah.
we'll just.
Oh, yeah.
It's okay.
I did look,
Wish I had
That's
better.
what I was choosing to write over my parents.
I just wanted to, you know,
Fair enough.
I just thought they're also have 20 minutes, like, a piece.
Yeah.
But, okay.
Different things, or something.
Yeah.
Cool that you get to be
Yeah,
a part of this, as part of your program. It's really cool you get to be a part of this as part of your program.
Yeah, yeah.
Just so you're aware, there's only 3 presenters in this room. So you will have up to 16 minutes to talk and then 4 minutes past that for questions. Got it. So you'll have a little bit more, if you want to use it.
I'm a very fast talker. I'll probably take 8 minutes, but.
You absolutely do not have to use it.
So you're Ayse,
I'm Ayse.
Ayse
Yeah.
and Carlos, I'll be moderating the,
Okay,
okay?
okay, great. Yeah, I'm a
Ayse,
preventive
yeah,
Ercumen.
Arjuna, the C pronounced
Like a
as D, J, Arjuna,
That's
Ayse,
right.
Arjuna,
Yes, thank you.
sorry. All right.
No, I respond to a variety of things. If you get the first name right, we'll learn this.
Nice. So, 1 minute.
They were only people this morning.
Yeah, somehow, some way in the settings.
Yeah.
Pretty well, it's in- that's what you're at.
Like, okay, there we go.
Shall I start? Okay. So, good afternoon, everybody.
Okay.
Thanks for coming to this session. That will be about, just for you to make sure that you are in the right room. It's the WaSH interventions. So be sure, sometimes I get lost here, so I only realize that I'm in the wrong room when the presentation starts. So that's why I'm making this. So the first presentation will be made by Kelly Endres, and she will speak about process evaluation for the delivery of a water, sanitation, and hygiene mobile health program in the Democratic Republic of the Congo. Preventive intervention for cholera for 7 days program. Kelly? Go ahead.
Great. Well, I guess I'll go ahead and get started. Thank you guys all for choosing to come to our room. We're very excited that you are here. As he said, my name is Kelly, and I'm with the Johns Hopkins Bloomberg School of Public Health. And today I'll be presenting on a process evaluation that we completed of our preventative intervention for cholera for 7 days, or PICHA-7 program, where we deliver a water, sanitation, and hygiene mobile health program in the Eastern Democratic Republic of the Congo. And so first, I have to say that I am only here because unfortunately, the lead author and presenter for our work, Amani Sanvura Presence, was not able to attend the conference. He had some issues with his visa being delayed. And so I'm very grateful that he asked me to present on his behalf. Presence is the data manager and project coordinator for the PICHA-7 program based in Bukavu in Eastern DRC, and he's at the Université Catholique de Bukavu. So thank you, Presence, for letting me present for you. So some background on our study. Despite decades of hard work, especially a lot of work by people here at this conference and our colleagues around the world, diarrheal disease remains a major contributor to morbidity and mortality, particularly in low and middle income settings. And one aspect of this that we know is that household members of diarrhea patients are actually at a much elevated risk of diarrheal diseases than the general population. And this is particularly true for cholera, where we've seen 100-fold greater risk for household members. And this is particularly true for that 7-day high-risk period after a diarrhea patient is admitted to a health facility. And we know there's a variety of reasons for this. This doesn't surprise anyone. Things like shared risk factors that are occurring at the same time, and then also transmission between household members. So while water and sanitation infrastructure is an important component of diarrheal disease and transmission, protective behaviors, so things like hand washing and water treatment, are also really important. And it really comes as no surprise to anyone here that behavior change is really challenging. That's why a lot of us are here. And it requires consistent reinforcement and really benefits from tailored interventions that are targeted to the population behaviors that you're working with. And one method that we have to for behavior change is through phone-based reminders and other mobile health technology. And this is something that we've seen big increases in, especially post-COVID, and then also in more higher income settings. But we know that mobile phone coverage and access to mobile technology is increasing significantly every year in developing settings. And there are interventions that are starting to leverage these mobile health networks, but there can always be more. And particularly in the WaSH setting, there aren't many that are implementing this. So this leads us to the question, how can we leverage the mobile network to improve diarrheal disease outcomes? So while not the main motivating question for our work, this was something we were able to explore as we developed the Preventive Intervention for Cholera for 7 days, or PICHA-7 program. And I won't have to keep reading out the acronym for you now. I think we've said that 3 or 4 times. But this was really something that we developed given the high risk of diarrheal diseases in our context. And we actually based it off of other work that you may have heard discussed at this conference before, our CHOBI-7 project in Bangladesh, where we found that the program we developed reduced diarrheal disease for household members and also increased some of our targeted protective behaviors. So we used a lot of formative research and focus groups, semi-structured interviews to develop our intervention. And we deliver pictorial modules in the health facility, in home visits, and then we complement this with a mobile health component. And we named it PICHA because this is the word actually in Swahili for picture, which represents the pictorial modules that we're delivering, and then 7 for that 7-day high-risk period for cholera and diarrheal diseases after admittance in the health facility. And today I'm specifically going to be focusing on the mobile health component of our intervention. So the mobile health component was developed during our intervention planning workshops, but after our pictorial modules. And we wanted it to align closely with the information that we're presenting and to really target the facilitators and barriers of our promoted WaSH behaviors that we identified in our exploratory research so that we can emphasize the messages that we're giving to our participants. And then these are the specific behaviors that we're targeting. So cholera and diarrheal disease transmission, hand washing with soap, water treatment and safe storage, and household hygiene practices. And there were 3 types of mobile messages that we delivered that I will go through. So we had SMS messages, voice calls and interactive voice response. And these were delivered through our Engage Spark platform program that we work with. So these are pre-recorded messages that we're able to deliver at specific times. And we actually created 2 different characters to deliver these messages. And so we had Dr. Picha, who is a doctor at a local hospital who treats cholera and severe diarrhea patients. And then also Mama Mwanza. She's the mother of a young child that fell ill with cholera and then had to take them to the hospital for treatment. So in a similar place as many of the participants in our study. And Dr. Pitcher was actually represented by a real member of our study team, who was a doctor at a local hospital, and she helped us create the recordings of our messages. And so one of the messages you might not be familiar with is interactive voice response. So SMS messages you get on your phone, like a text message, voice calls, or recorded messages you receive like a call on your phone. And then IVR messages are a voice call that you receive and then reads out a little quiz that then you can respond 1 or 2 on your phone, and we can see what responses are being sent. And this is just an example of one of our messages. I shortened it so I'm not overwhelming you with a lot of text, but you can see here that after the question is asked, what is the correct way to boil your drinking water? The participant is then read, they can press 1 for this answer or press 2 for this answer. And then after they send their response, they'll receive a message that either says, your message was correct, thanks for, your response was correct, here's why it was correct, or sorry, that was incorrect, and then this is why it was incorrect. And so we enrolled patients when they were admitted to the health facility and their households, and I'm not going to go into this. If you have more questions, feel free to ask. They were then randomized to a standard message arm and our Pitch 7 arm, which had those components that I discussed. And this is the participants that I'll be talking about today, because we're really looking at, this is a process evaluation. So were participants receiving our messages, and how were they interacting with the messages that we sent? So our study site is in Eastern Democratic Republic of the Congo in a city called Bukavu. If you were just in the breakout session that dealt with Eastern DRC, you have a really good background on our study area. We did our study from March 2020 to November 2021. And then for this component, we had 76 households. And just to give you a background, it's estimated that 45 to 54% mobile phone coverage in DRC. And of course, this is higher in our urban sites, and this will be lower in rural areas. So our first result is looking at fidelity, which is the messages that were received by the participants. So the percent of messages that were received. And you can see that the vast majority of our messages were received by our participants. And here we're looking at unique messages. So did the household receive at least one of each message type? Because these messages were sent to all of the participants with phones in the household. And something that was really exciting too is that none of our voice or IVR messages failed to send to households. So received means that they actually they answered the phone. The other 12 and 11% didn't answer, but they were all received by the phone of the household member. And then this was similar across our study period. And then also we were able to look at the message responses. So how are participants responding to those IVR quiz messages that we sent? And overall, over the study period, 65% of households replied to these messages. And then of the households that replied, 73% of the answers were correct, which is a pretty high percentage, and we're very excited to see that. And while we're only presenting these, the responses to our messages, so the program evaluation, in our Bangladesh work, we found that a correct response was associated with less diarrhea and better water treatment when responding correctly. So we're looking forward to then looking at that in our further results. I also forgot to mention, these are the results from our pilot. So this study is, this was 3 months long, and these messages were sent weekly to our participants. Sorry about that. So then in conclusion, we were excited to see really high fidelity or high messages received by the participants in our program, and a generally high percentage of questions that were responded to correctly. And we find that delivery of this type of mental health program is feasible. Obviously, there were challenges, but these messages were received and interacted with by our population. And then, as I briefly mentioned, we're in the process of conducting the full randomized control trial. I know I forgot to mention the pilot part earlier, but we're currently conducting the full randomized control trial of this work to determine the overall effects of the PITCH7 program, and then also to really get into understanding the impact of our mHealth intervention. And of course, there are many people whose hard work went into this project, both our large team in the DRC, our team at Johns Hopkins, our collaborators in the Ministry of Health, and then our funding through the Wellcome Trust. And then this is an image of our study team. And then if you have any questions, please reach out to Presence. I know he was really disappointed that he wasn't able to attend here, and he would be glad to receive any further questions and feedback that you have. So thank you. And yeah, if you have any questions, I'm welcome or happy to take them now. Yeah.
Do you happen to know on the list of questions, there was one that had like an 18%?
Yeah.
There's like one question, everything else was pretty good.
Yeah, so I wanted to show them all, but basically we had vetted all of our questions a lot through our formative research and a pre-pilot. And had pretty good responses to all of our questions and understanding. And then when we were looking at our results, we found that it seems like people just really didn't understand that question. And so when we were looking at it again, we could see that it could have been maybe worded in a way that they didn't understand or something. So that's something that we're looking at more in our RCT data. But I was also looking back at that and like, oh, that's interesting. But that's why we think that there's that question. And we're going to do some more qualitative interviews and things, and have done some with participants where we're going to look at that more. Yeah. Yeah, so that's something that we've also been looking at a lot. And so for our study, something that we've been working on is actually the majority of our participants are women, because they're the ones who are in the household and are generally more likely to participate. So a lot of the men aren't present during the day or might not interact with them. But I think that the majority of the phones were actually still owned by the women. But that's something we do need to look at more. And so because there were more than one phone in most of our households. Yeah.
Did the number of people answer the phone reduce over time, because they do that are from you and they might know what kind of questions, so they might not want to bother anymore. So,
yeah, so we actually, when we looked at, so first of all, no, this didn't go down as much as we expected. And especially we wanted to look at was at least one of each message. So for sending this to multiple phones in the household, was at least one of each message replied to. And so I think I briefly had that, or I might have not had that part. Oh yeah, sorry. So you can see that the percent of quiz or messages that was replied to was actually fairly consistent throughout the study, which was something we were happy to see. Thank you.
thank you, Kelly. So our next speaker is Ayse Ercumen, correct?
Yes.
And she will talk about can WaSH nutritional interventions reduce antibiotic use? Evidence from cluster-randomized controlled trials in Bangladesh and Kenya.
We're working on it.
Okay, don't worry. No.
And I guess I'm not officially old enough to need like tech support at these events. Hi, I'm Ayse Ercumen. That was very close. I'm from North Carolina State University. And I'm going to talk about the effect of water, sanitation, hygiene, and nutrition interventions on antibiotic use in rural Bangladesh and Kenya. All right, so low and middle income countries have a high burden of diarrheal and respiratory infections, which get treated with antibiotics often, even if they are viral. And in these settings, antibiotics are often readily available over the counter, leading overall to high use. So pediatric antibiotic use per child year is about 10 courses for a child in Bangladesh, something like 4 in Kenya compared to less than 2 here in the United States. So we care about this because early life antibiotic use is associated with a slew of health outcomes down the road, including antimicrobial resistance through selective pressure for resistant strains in the gut, but also microbiome alterations, right? So diminished diversity and richness of the microbiome because of frequent antibiotic exposure is associated with a slew of health outcomes down the line, ranging from asthma to diabetes to mental health, right? We care. Like also, increased exposure to antibiotics is associated with increased risk of further diarrhea, and that can propagate the feedback loop between diarrhea and malnutrition. So water, sanitation, hygiene, and nutrition improvements can break or interrupt these processes at a couple of different places, right? Sanitation interventions are primary, they sort of prevent the spread of pathogens into the environment. You have secondary barriers of water treatment and hand washing, preventing the spread of pathogens to their ultimate hosts. And nutrition improvements can break that vicious cycle between diarrhea and malnutrition. So a modeling study, and right, like we sort of if you go back to this causal diagram, plausibly we anticipate, right, that interventions of this nature are going to bring down antibiotic use. But there is actually very little empirical evidence on this relationship. A modeling study estimated that universal access to improved water and sanitation would bring down diarrhea cases requiring antibiotic use by 60%, but it was a modeling study. There is a single randomized controlled trial to date by Amy Pickering and her team, and that found community water chlorination in urban Bangladesh reduced antibiotic use by 7% in children, right? So it's just one study that's out there. So we were interested, our objectives were to assess the effects of water, sanitation, hygiene, and nutrition interventions on pediatric antibiotic use in rural Bangladesh and Kenya, using data from the WaSH benefits trials, which implemented a range of interventions, both individually and combined. The interventions were household level water treatment with chlorine, and in Bangladesh specifically, also safe water storage, sanitation improvements, including pit latrine upgrades, child potties for the ones who don't get the memo to use latrines, right, and then hose and scoops for managing child and animal feces, hand washing stations with soapy water near the kitchen and latrine areas, and nutrition improvements, including lipid-based supplements, and also nutrition counseling for maternal nutrition and infant feeding. And we were interested because the trials implemented interventions both individually and combined, we were interested in understanding what is the effect of both individual and combined packages of these interventions on antibiotic use. And we're interested in understanding heterogeneity by child age, both on antibiotic use and on intervention effects, right? Is this sort of working better or worse in certain age groups of young children? So both WaSH benefits trials, so both in Kenya and Bangladesh, the trials enrolled pregnant women, and the intervention hardware was delivered in the final trimester up to pregnancy. And the goal here was to really intervene on that environment that this new cohort of children are going to be born into, right? Kind of make sure that it's hygienic before the kids are brought into it. Behavior change promotion and free supply of intervention products was provided throughout the duration of the trials. And it targeted the compound where the enrolled pregnant mothers and their newborns lived. And these newborns, I'm going to be referring to them as index children going forward, right? They're the birth cohort that's born into that sort of presumably more hygienic environment. We measured intervention uptake throughout the 2-year study duration, and it was high and sustained in Bangladesh for both of the years. It was lower and more variable in Kenya, particularly low in the 2nd year of the trial. All right, so you may have seen this before if you listen to WaSH benefits presentations. Like this is just a schematic that's showing the different arms of the WaSH benefits trials, ranging from controls up top to individual water, sanitation, hygiene interventions, and then combined intervention packages. And antibiotic use we measured only among a subset of these study arms, including the controls, the arm that got the combined water, sanitation, hygiene intervention, the nutrition intervention arm, and then the arm that got nutrition plus water, sanitation, and hygiene. And we measured antibiotic use at 3 different times. In Bangladesh, when the index children, when the birth cohort, when they were 3 months, 14 months, and 28 months old. And in Kenya, at the ages of 6, 17, and 22 months. And it was a subset of the children who were enrolled in those arms of the study. We recorded caregiver-reported antibiotic use for the index children in the last 90 days. And we tabulated whether during that time, the children had used antibiotics at least once, whether they'd used it multiple times. We also recorded the number of episodes of antibiotic use and the total days of antibiotic use. We compared these metrics, both between intervention arms compared to controls, but because we're interested in also do combined interventions work better, we also compared that the guys who got the full combo, nutrition plus WaSH, compared to just nutrition or just WaSH alone. We used generalized linear models with robust standard errors. Our primary analysis was unadjusted because randomization achieved really good covariate balance. For the primary analysis, I also pulled all data from the 3 different time points when we measured the outcomes, but we did subgroup analyses by age, where we looked at one of those time points at a time. And our pre-specified analysis, if there's folks who want to learn more, is available on OSF. All right, so moving on to results, antibiotic use in children was high in both countries. So in Bangladesh, about 2/3 of the children, and in Kenya, about half, had used antibiotics at least one time in the last 90 days. And in Bangladesh, about a quarter, and in Kenya, 13% had used antibiotics multiple times in a 90-day period. Once we broke this down by age, right, this is just this is looking at sort of now using antibiotics at least once or at least or multiple times, and broken down by the countries and by age group. What we found in Bangladesh was that antibiotic use was at its highest at the 14-month age point, right? So about 3/4 of kids at that age had used antibiotics at least once, and 35% multiple times. But you can see in Kenya, there were no age patterns. So use was sort of similar across the different time points where we measured it. All right, so now this is a forest plot that's looked at showing intervention effects on antibiotic use in Bangladesh. And let's kind of walk through what's happening in this forest plot, right? The x-axis is relative risk. That's comparing study arms to each other. And on the y-axis, the top 3 comparisons, the ones in black, are comparing intervention arms, water, sanitation, hygiene, nutrition, and nutrition plus WaSH to controls. And then the bottom 2 comparisons shown in blue are comparing nutrition plus WaSH to WaSH alone, then nutrition plus WaSH to nutrition. Yeah, and then the different panels are the 4 different metrics of antibiotic use that I described before. Now, if you focus on the black dots, right, just on the estimates compared to controls, we can see that all interventions across all metrics reduced antibiotic use in Bangladesh, right? And it was about a 10 to 35% reduction across the different metrics. However, if you focus on the blue estimates, right, we see that there's no added benefit from nutrition plus WaSH when you compare it to nutrition alone or to WaSH alone, right? So no synergies there. And I'm not showing a forest plot for Kenya, but there was no intervention effects on antibiotic use across any of the metrics in Kenya. So this is now, we're switching to a table format. This is now showing effects broken down by age group in Bangladesh, right? And I'm showing prevalence ratios for comparing WaSH, nutrition, and nutrition plus WaSH to controls. And above, I have antibiotic use at least once, and the bottom rows are multiple times of antibiotic use in that time period. And we can see, right, that the strongest effects, the largest reductions in antibiotic use, were found in the youngest children, roughly at the age of 3 months. So that's what we're seeing across the board, across all both metrics and the different arms, the strongest reductions in antibiotic use from the interventions. Looking at the same data broken down the same way for Kenya, there was no significant reduction in any age group in antibiotic use metrics. So in summary, we found reduced antibiotic use among children that were randomized to receive WaSH, nutrition, and nutrition plus WaSH interventions in Bangladesh, but not in Kenya. Right, so this is consistent with the intervention effects on diarrhea that we have previously published in these studies. Right, in Bangladesh, we found that every intervention other than individual water treatment was effective in reducing diarrhea, and in Kenya there had been no effect overall, right, in any of the intervention arms. And our findings on antibiotic use, right, that's sort of internally consistent, reflect that pattern of findings. That's possibly due to the lower uptake of the interventions in Kenya, right? That's one way to think about it. And then another finding from this work was that there was no added benefit from combining nutrition and WaSH into a single package. So this information can augment antibiotic stewardship programs that are looking into right, so reducing antibiotic use. And future studies should really look at downstream effects. Does this reduced antibiotic use translate to reduce community carriage of antimicrobial resistant bacteria? And we also want to look at sort of downstream effects of microbiome health, especially given, right, that we saw the strongest effects among the youngest children whose microbiomes are actively developing. So they're going to be more vulnerable, right, and potentially more able to benefit from those reductions in terms of microbiome health. This was a huge effort, so I'm just going to shout out, so thank you to all my colleagues from Kenya, Bangladesh, and the US. And I guess with that, I'm taking questions.
Can the moderator make the first question? How to separate out antibiotics for diarrhea for other disease, ear infections? Small kids, they have this all the time. So my son now is with an ear infection. So
Yeah, so we did not separate at all, right? And also one secondary outcome that we looked at was respiratory infections, right? So it's really could have been antibiotic use due to like kind of any illness, right? But we are thinking the biological plausibility behind the whole thing is we are anticipating if there's enough reductions in some of the illnesses out there, right? That's going to reflect in reduced antibiotic use. Yes.
Nice presentation. My question is further on the age categorization.
Yeah.
And you said 3 months gave a better effects in reduction of antibiotic use, right? What kind of food sources? For 3 months, were they on breastfeeding, or they feeding from food that is made from synthetic products, compared to those older.
Mm-hmm.
So because most times those things also play with illness, depending on how healthy the child will be and how vulnerable the child will be to the environment as well.
Mm-hmm.
So, I wanted to get a picture on that.
Yeah.
Help me understand why you're having that result as well.
Yeah, no, that's a very good question. There's 2 points, right? Antibiotic use was actually like higher at the 14-month point, but the intervention effects were stronger for the youngest kids. Now, in terms of what they're eating, exclusive breastfeeding, I think, is terminated relatively early in these settings, but like there's a slew of Bangladeshi colleagues in the back, so correct me if I'm wrong. But I think so adding on complementary foods and sort of consumption of water kind of goes hand in hand with breastfeeding, so at a fairly early age. So I just would anticipate it's just a mix of exposures. I think the way I was thinking about it also, like there's 2 components. There's sort of like what goes into the mouth intentionally, and then what goes into the mouth unintentionally, right? So like a colleague mentioned having kids, right? There's also a lot of exploratory behaviors, like when kids are kind of gaining motor skills and really experimenting with the environment, a lot of accidental exposures. And in that youngest age group, we're just seeing sort of the strongest protection from water, sanitation, hygiene, and nutrition, sort of through whatever mechanism.
Thank you.
Yes.
So I recently saw a presentation about reduction in diarrhea for the Washington, which is very seasonal, right? So is there also a seasonal trend in reductions in antibiotic use? Is that something you guys try to lay over the seasonal trends in diarrhea?
Yeah, that's a very good point. It's probably one more separate analysis I should do. So we have been finding across our reanalysis of the WaSH benefits trials that a lot of those reductions in diarrhea that I was alluding to are concentrated in the rainy season, and the effects are much sort of like less pronounced when things are dry, presumably because there's less disease transmission. So you kind of get more bang for your buck for the intervention during a time when there's a lot of bugs circulating around. So yes, I should look into that for sure for this too. Yes.
Hi, I have a quick comprehension question. In terms of the age groups, were only the 3-month-olds in the birth group? Okay,
Yeah.
Gotcha. So the 6-month-olds and the 9-month-olds started like at 3 months or 6 months.
Like the same cohort of children, and they were just born into the cohort after the interventions were delivered, and we followed them longitudinally at different times in their lives. It's more or less the same group of kids, right? Like give or take, some like are lost to follow-up, right? And things like that. Some you can find at one time, but not the other. But it's a longitudinal cohort that's aging, and we're tracking the antibiotic use along with that. Yes.
So first of all, congratulations for your work. I can see a lot of value to your health. And I see more of your. So I was wondering how easy it is to buy antibiotics in Kenya or in Bangladesh?
So I recently traveled to Bangladesh in August, and I bought a box of Superflexes on my way back. I think it's relatively easy, is my understanding. I can speak less about Kenya. I have not worked there in person. This was a big group effort. My understanding is that, right, like things are available over the counter, Superflexes was like no issue to get my hands on, I just stocked up on my antibiotics on the way out, like before flying back to the US.
Yeah, because I'm from the Philippines some years ago, and everyone could buy in the drugstore antibiotics. But right now, just with deliberation of the doctor getting some virus. So I don't know if this kind of thing that we're okay.
I mean, it's certainly where we want to go, right? I mean, when I talk about antibiotic stewardship and saying these types of interventions are going to be effective in bringing antibiotic use down, right? Those are the dialogue partners about what are some other ways we can bring it down, and certainly making it less available, harder to get to is part of it, right? But then sort of the upstream part is also, right, so improving the conditions that require antibiotic use in the first place. Yeah.
Just a question on the antibiotic use. So did the household specify if it's antibiotic use that's self-prescribed, preventive, and then clinical care, just out of interest?
Yeah, I don't think we collected that information. We just listed. I mean, I think one thing that was gnarly also, just like how do we make sure that when they say antibiotics, they mean antibiotics, right? There's like paracetamol and like fever reducers and like anti-emetic drugs. So we just compiled a list of sort of like 20 or so commonly used antibiotics and inquired about them specifically. And then kind of compiled the data into like a yes and no binary variable. I don't think we collected though, like whether it was prescribed or people kind of just opted for it themselves.
Ayse.
Oh my God.
So next presentation, where am I? Okay, will be Jess Contreras, and he will be talking about improved child feces management, mediate reductions in childhood diarrhea from on-site sanitation intervention, causal mediation analysis of a cluster-randomized trial in rural Bangladesh. Thank you.
Thank you. Hi, everyone. Thanks for being here. Ayse's presentation, unfortunately, really set mine up very well because she was my advisor for this and it's in the same project. I'm Jesse Contreras. I'm currently a postdoc at University of Michigan, but this is my work with Dr. Ercumen at NC State. And we conducted a causal mediation analysis to determine which specific aspects of a multi-component sanitation intervention were effective in reducing the prevalence of diarrheal disease in children in the WaSH Benefits Bangladesh trial. This analysis was based on a sub-study led by Dr. Ercumen, nested within the larger WaSH Benefits Bangladesh trial. And the larger parent trial implemented multiple interventions, as you mentioned, but the sub-study sampled only from the sanitation intervention arm and the control arm. The sanitation intervention was an on-site latrine-based intervention implemented at the compound level. In rural Bangladesh, a compound is what is shown in the picture. It is a group of households built around a central courtyard, which is shared by members of the same extended family living in the households around. One household with a pregnant woman was enrolled as the index household, as mentioned. But since any household in the compound can contaminate the shared environment, the intervention was implemented for all households in the compound. Each household had their latrine upgraded if they had one, but only the index household was provided a new latrine if they didn't already own their own. All households were provided a Sani scoop for managing child or animal feces and a child potty if they had a young child. Field staff visited the households about 6 times per month for in-person behavioral promotion, and that promotion was primarily targeted to the index household again, but all households in the compound were invited to participate. The parent trial included 720 sanitation intervention recipients and a double-sized control arm. For the sub-study, we randomly selected 360 compounds from each arm for a total sample size of 720 compounds. And we visited each compound 8 times, about every 4 months over 2.5 years. The study started about 1 year after the intervention was implemented and continued until about 3.5 years after implementation. And in a study I presented at last year's conference, we showed that the intervention's effects on diarrheal disease were maintained in the sub-study, with the diarrheal prevalence moving from 14.5% among controls to 11.9% in the sanitation arm. And in regression models, we estimated a prevalence ratio of 0.81 and a prevalence difference of 2.7 percentage points. We also found that the intervention's effects were exclusive to children living in those index households who were the primary targets of the intervention. So among children living in index households, the intervention led to a 26% relative reduction in the prevalence of diarrhea and an absolute reduction of 3.7 percentage points. Whereas among non-index households, the intervention had no effect on diarrhea. And because of this effect modification, we limited our mediation analysis to include only children living in index households. So after that, our total sample size was 6,476 individual outcome measurements over those 8 rounds. And for one final breakdown, we also found distinct seasonal modification of the intervention effects, with stronger effects during monsoon seasons compared to dry. Effects during dry seasons were marginally significant, and I love marginally significant things. So we did retain them for the mediation analysis, but we estimated all effects separately by season. And the prevalence differences on the screen of 4.5 and 2.3 percentage points are useful to keep in mind for the mediation results that are coming up. So it turns out that finding reductions in diarrhea from sanitation interventions, particularly on-site sanitation interventions, is extremely rare. So we wanted to understand what it was about this intervention that made it unique. But since the intervention was multifaceted, we didn't know which of its many components were actually contributing to reductions in the prevalence of diarrhea. And that's where mediation analysis comes in. The general goal of a mediation analysis is to determine how much of an independent variable or intervention's effects on an outcome can be explained through some intermediate variable, which is called a mediator. In our case, the results I've already been showing are the total effect of X on Y, ignoring any mediating variables, but it's possible that some portion of that effect was enacted through an intermediate variable, like that. The portion of the effect that goes through a mediator is called the mediation effect. And in the counterfactual based framework for mediation analysis that we used, which is described in this paper on the slide, if you want more information, this effect is called the average causal mediation effect, or ACME. So once you've accounted for the mediation effect going through the mediator, there may be a residual effect of the intervention that did not go through the mediator. That leftover effect is called the direct effect, or average direct effect in our study. And so if the ADE were to reduce all the way to 0, it would suggest that 100% of the intervention's effects were mediated through the particular mediator. So that's the setup. Our goal was to estimate ACMEs and ADEs for 38 variables that we considered potential mediators. They'll each be shown in the results. So just for clarity, we conceptualized the potential mediators into 3 categories: latrine quality indicators, latrine use practices, and feces management practices. Each individual mediator within those categories was analyzed in its own separate model, since a 38 plus covariate model would have dimensionality problems. And these individual models are causally valid so long as we don't think that one mediator is causing another one. Of course, we did think that some mediators were causing other ones. Specifically, we assumed that latrine use practices depended on the quality of the latrine. Our statistical models fortunately allowed us to account for this. So our models for latrine use practices account for any significant mediators that were in the latrine quality category. We also accounted for potential confounding of the mediator outcome relationship, which could show up since the mediators themselves weren't randomly assigned like the intervention. We controlled for the same variables in every model, which were child age and sex, drinking water source, housing materials, mother's education, food insecurity, and household assets. And as one final caveat, I have to point out that the mediators and the outcome were technically measured at the same time. And so mediators didn't precede diarrhea since they were asked in the same survey. That means our analysis is only causal in as much as the mediators that are measured today reflect what they would have been 1 week prior. I think that's a fairly safe assumption, so I do consider this a causal analysis. So back to the simplified figure for a single mediator, I'll quickly go through the 3 steps of our analysis, which were repeated for each mediator. First step is to estimate the intervention's effects on the mediator. Did the intervention actually increase latrine quality or reduce open defecation, et cetera? And if the intervention didn't have an effect on the mediator, then there could be no subsequent mediation. So we discarded the variable for the next steps. In the second step, the outcome was regressed on both the intervention and the mediator in an adjusted model. So this assessed whether controlling for the potential mediator changed the intervention's effect, and also checked if the mediator was associated with the outcome adjusting for intervention. And that's also required for mediation. And in the final step, the first 2 models were fed into an algorithm using the mediation package in R, which generated 1,000 Monte Carlo simulations of the results, and then sampled those to produce mediation effects with 95% confidence intervals. The specific statistical equations are over my head, but the approach is based on a counterfactual framework. It's very flexible to different types of variables, different forms, and all sorts of different types of models, which was really great for our analysis. So moving into our results, we found that most potential mediators were in fact improved by the intervention. Of 38 variables we started with, 8 were not impacted during monsoon seasons and 9 were not impacted during dry seasons. And some of these weren't surprising because they were just so rare in general, like the presence of human feces in the courtyard, like less than 1%, or the youngest children who are under 3 using latrines, also very rare. But these are the variables that didn't continue into the following steps. And now I'll quickly present the estimated mediation effects by type and by season. The plots are similar to what Ayse presented. The specific mediators are shown along the y-axis. Some are shortened, so apologies if they don't make sense. And the effects span the x-axis, but instead of being ratios, these are reported as prevalence differences in percentage points. So an estimate of -4 could reflect the prevalence of diarrhea going from 14% to 10%. Average causal mediation effects are plotted as circles with 95% confidence bars, and they tend to hover closer to that vertical dotted line at 0, which represents no effect. In the case of latrine quality indicators in monsoon seasons, which is shown on the slide, there were no significant mediation effects. And average direct effects are plotted as diamonds without confidence intervals, just to save clutter on the screen. And again, these reflect the intervention's residual effect that did not go through the mediator. Here, the direct effects were pretty consistent between 4 and 5% because there were no significant mediation effects pulling them closer to 0. Staying with latrine quality indicators, but moving to dry seasons, increased access to a flush latrine had the only significant mediation effect, and notably accounted for 100% of the effect of the intervention, as the direct effect scooted all the way to 0 and actually passed it a little bit. So a flush latrine was the only significant mediator. Next are latrine use practices in monsoon seasons. These included latrine sharing, open defecation, and frequency of latrine use. Reduced open defecation, increased latrine use by children specifically had the largest mediation effects. Although all of these effects were under 2 percentage points and the direct effects were still significantly larger. So these were significant and might say something, but any individual effect should be considered with its magnitude. Results were similar during dry seasons for latrine use practices. It's still mostly open defecation for children, but fewer of these ACMEs were statistically significant. Feces management practices included use of a potty and use of the Sani scoop provided by the study for feces management. And increased potty use had the strongest mediation effect during monsoon seasons at about 2.5 percentage points, followed by safer child feces disposal and handling. And then use of the Sani scoop for feces disposal as well. During dry seasons, child potty use seemed even more important, going way off to the left. And we got this odd result for potty use in which the intervention's direct effect actually ended up harmful. I think this is just an artifact due to the fact that the intervention had a huge effect on potty use because it was provided by the study, and so it wasn't very common in the control arm. And it was operationalized as an ordinal variable, and ordinal regression was really fun to do, but I don't know if it often creates wonky results. So this is something I didn't notice until it was on a slide, and I will look more into it. And so here are the results plotted together. It's a lot of detail, but I think looking at the colors of the statistically significant mediation effects kind of tells a story. There's a strong suggestion that improved child feces management was the driver of the intervention's effects. The strongest mediators here were potty use, reduced open defecation among children, and safer handling and disposal of child feces. Now, theoretically, we should be able to just add these up and they should sum to close to the total effect of the intervention. But in our case, that sum actually far surpasses the total effect. And that seems to be because these mediators were all impacted by the same intervention. And so they are all moderately correlated. None of them were so strongly correlated that they were redundant and we didn't have to remove any, but a household where fewer children under 3 open defecated was probably more likely to have reduced open defecation in slightly older children, for example. So instead of focusing on any specific numerical estimates, I think the broad trend of mediation through child feces management is the most important takeaway. And in dry seasons, the pattern is similar, but effects were attenuated because the total effect was smaller in dry seasons overall. The specific results in dry seasons was that a flush latrine was more important, and that wasn't a significant mediator in monsoon seasons. And I think that makes sense, and also just reflects the importance of seasonal water needs and seasonal water access, potentially changing the disease risk. So our analysis suggests that improved child feces management was the most important component in the WaSH benefits Bangladesh intervention that produced reductions in diarrhea, which resulted from intensive in-person behavioral promotion and free provision of child feces management tools, the Sani scoop and a potty. So it was a robust and very thorough intervention to achieve these results. And these effects might only be possible due to the specific context in which the study took place. Here, sanitation norms were fairly good and access to improved latrines was already pretty high before the study began. And so I think it's very difficult to generalize WaSH studies and WaSH interventions in general outside of their local context. But in settings like this, these results suggest that child feces management is what's most important. And as a last note, I want to highlight how mediation analysis is a wonderfully flexible tool for assessing intervention effects. Our study focused on health effects and specific behaviors and quality indicators that were potential mediators. But there was this preceding study that I'm a fan of from Christine Marie George and others that also use mediation analysis to assess how hand washing behavior change was achieved through psychosocial factors like self-efficacy and knowledge of diarrhea. This is in the Chobe mobile health trial. And I just like comparing these two studies because they show that you can look at many different types of pathways and conceptualize different ways that intervention effects can provide benefits. So thank you. And as I take questions, here's just the results again.
Thanks for the presentation. I know you said that you saw the greatest reduction in the index household, but I'm curious if you looked at all at how, the effect could be mediated by changes in child feces practices within the own index household versus within the other households in the compounds where like children in the index household could be exposed to other people, like other children's species within the compound.
I would have to look into the data closer again to see if that were available. I don't think it's that granulated for like separating out the different households. It's either it's the respondent in the index household saying either what happens in their home specifically or being asked generally like what do people in your compound do, but potentially could be applied as well.
Nice presentation. My question is on the feces itself. You're looking at human feces, right? But do they have animal cells where animals interacting with the environment, and the children can also interact with that environment that animals interact with, because animals also have certificates within the environment. So all that also, do you look at those factors?
Yeah, it is pretty common in the setting to have animals within the vicinity, including within the compound. So those were considered, probably not worth looking, those were considered as potential mediators, primarily thinking that the scoop that was provided, which was part of the promotion, was use this to remove animal feces and get it out of the way of where children are playing or just remove it from the environment. So that was one pathway through which maybe the intervention was going to have effects. Cattle feces was the only one that the intervention impacted, so the only one that made it onto these, and it's pretty far up to the top, wasn't a significant mediator. And then for like goat feces, poultry, dogs, cats, those weren't changed by the intervention. The intervention did change people using the scoop for animal feces. So I don't know if it's just because there weren't as many poultry or anything, but that didn't end up in the analysis. Thank you. All right.
Any more questions? Well, thank you, Jess, but I'd like us to stay here. I'm gonna call all the speakers to come to the table and open the space for more questions from, maybe you have some questions for the other guys that are presented. So please.
A surprise debate.
Try. Okay, so any more questions? Take your time, you still have 20 minutes. They say that you can ask anything, they will answer, don't worry. Yeah, in the back.
All the presenters, you did an excellent job. However, I am interested to know more from the how you are planning to use for next analysis. Like, it's a lot of analysis. How you are thinking from the future WaSH analysis. Anyone can respond.
So I guess I can go first quickly because it's pretty easy for us to say since we were just looking at the process evaluation from just our pilot data. Next, we're looking at our much larger RCT and actually seeing now that these messages are delivered and interact with and received, are they actually making an impact on the behaviors and outcomes that we're targeting? So those are the next steps for us.
This is on, right?
Yeah.
I have been fascinated by all of the null effects for sanitation interventions for quite a while now. And that really inspired me to try and work on this project, so I was really excited to. I really would like to see a little more return to something basic to see like why these aren't working, how pathogens are moving through the environment. And my favorite place that I've done research is in Mexico, where they irrigate a huge swaths of land with wastewater from Mexico City. And I'm excited to try to look at pathogen transmission in that context because there's such a clear source of pathogens that's just like full of it, whereas latrines, if you just have one in a compound and they're all spread out, I think it's hard to get the power to these analyses. So I also think just identifying very contaminated places and seeing how pathogens move around anywhere is a great idea.
I'm really interested in figuring out whether, like, this really doesn't sound like it's on, but you said it's on. So whether these interventions where we did see a reduced antibiotic use, whether they do translate into reduced carriage of antimicrobial resistant bacteria. And, like a plug, right, like out there, we have archives 2 simples, right? So it's something that we actually could get funding and further investigate. And I think sort of to follow on Drew's points, so understanding whether there's seasonalities in these effects is important. And not really just binary like monsoon versus not. There's also a lot of sort of granular variation. Like some days you have a lot more rain than others, and really, right? Like does that move the needle also? Like are there uniquely vulnerable times, right, where these types of interventions are more effective? Immediately following heavy rain, immediately following extreme temperatures, and things like that.
I have 2 questions here. 2 questions from the people online. I think it's for you, Ayse. How you treat antibiotics defaulters in your data management, and as well as the potency or antibiotics and different types of antibiotics, heterogeneity.
Got it. So I'll start with the second one. I'll ask you to repeat the first one. So like how did we deal about potency of different antibiotics?
Yeah.
The answer is I haven't done it yet, but we do have the data on what antibiotics the children use. I don't think we're going to have power to say something about like, this particular class of antibiotics went down and this one went up. Like it's a sub-study. So we're just kind of binning everything together into, is it an antibiotic or is it not an antibiotic? But I think there's going to be some trends we can look at. What are the common classes of antibiotics that are used in this population, right? And compare Kenya versus Bangladesh and see qualitatively, like, is the needle moving maybe on some of them more than others? And could you repeat the first part of the question?
How you treat antibiotics defaulters, is that a word, in your data management?
Antibiotic defaulters in the data management. Yeah. Like defaulter would imply like someone who takes antibiotics kind of like rain or shine.
I don't know. I'm just reading what's here.
I mean, ultimately, we are dealing with caregiver-reported data on whether the child took the antibiotics within that given time period or not. There are studies out there that have looked at whether the self-reports checks out with clinical records of antibiotic sales and such, and it appears to be that caregivers do accurately recall and report. So we are sort of have faith in the data, but while recognizing it's self-reported.
You have categorized your research based on the infection for the children, 5 years. So we're talking about the antibiotics, right? So antibiotics is basically given to those who are infected by the bacteria. Then did you categorize the diarrheal infection either by the virus or the bacteria? Because basically the children below the 5 years of age are infected by the rotavirus. So I was looking for that point.
That's a very good question. So like the Achilles heel here is that kids are given antibiotics regardless, right? Like in a setting where it's common to treat diarrhea with antibiotics, even if it is rotavirus diarrhea, chances are you landed with some antibiotics that you needed to take. So what we're finding is, right, sort of like through whichever disease pattern, right, ultimately, if diarrhea equals antibiotic use, even if it's viral, right, being able to reduce diarrhea appears to translate then to reduce antibiotic use. However, we did have stool data from these same children, and we looked at intervention effects and to see, right, like what kind of diarrhea are we bringing down? And it was primarily viral. So there was no effect on bacterial infections. There was actually a reduction in viral diarrhea, indicating not only are we reducing antibiotic use, we're reducing unnecessary antibiotic use, right? Because it's really kind of, it's from those rotavirus cases that no longer now need to be treated quote unquote, with antibiotics.
The research is very nice because I have seen the specimen from children of very low age, maybe 1 or 2 years old. They are already resistant to a lot of antibiotics. Yeah, so this is a great research. Thank you so much.
Yeah, AMI carriage is really high among kids in Bangladesh, like upwards of like 80%.
For the health impact we mentioned at the start of taking multiple or many courses of antibiotics at a young age, are there differential effects for taking antibiotics basically when they're not needed versus taking antibiotics when there is bacterial infection and these where those antibiotics are correctly prescribed and are needed by the child?
That's a very good question. And I think the simple answer probably like it's better to take antibiotics when they're needed than when they're not needed. But a colleague of mine, Liz Rogoski, did an interesting analysis, right? There's also like whether or not you have overt diarrhea, you have like a whole bunch of other things in your gut. So anytime you take antibiotics, those whole bunch of other things, like those bystanders, are also getting exposed to antibiotics, right? So like it's not just the thing that you're trying to treat, kind of at any given time, whether you got diarrhea or not, you're exposing a whole slew of enteropathogens to antibiotics.
So what would you advise the Bangladesh government if you were in the position to advise them on how to manage this situation, this observations you made?
Antibiotic stewardship, right? Increased vaccinations. I mean, none of this is new, right? I mean, I think there's a lot of kind of antibiotic stewardship thinking that's out there. And if you can vaccinate kids before they get ill, then there's fewer things to treat with antibiotics, right? Sort of wise use, right? Like not trying to attempting to treat rotavirus diarrhea cases with antibiotics, but also, right, for us in the WaSH community, like it is actually really encouraging, right, given that there's a lot of thinking and a lot of momentum around AMR. And if we think that WaSH is going to make an impact, right, then that's just like one more, right, that's sort of like one more argument to strengthen the need for better water sanitation, hygiene, nutrition, all of the above.
Just to follow up, do you think that the government also should enact policies that will clamp down on indiscriminate prescription or easy purchase of such antibiotics drugs?
Very good question. I think anyone who wants to chime in, right? Like, do governments respond to these types of data?
For Jesse, in the next WaSH study at Sanvura, you just recommend focusing on child feces management? Okay, in a context with high liquid access in already.
Yeah,
I don't know what
probably.
Yeah,
I would do a very thorough review of all the literature I've never read before giving any advice to anyone doing real things. But yeah, I think that'd be, so long as the context has been assessed and taken into consideration, because the open defecation for children under 3 or just young children in general is incredibly common, even in places like this, like very high in the data set, like 91%, I think, of compounds with young children that was openly defecated wherever. And it's viewed in a lot of places as different, not unsafe. And so changing those attitudes seems like a target that's missed even in places that are achieving latrine access and good sanitation.
I also have a question for Jesse. I don't know what role you played in creating the survey, but at the conclusion of the survey, were there mediators you wished you had data on? Were there other factors that you wish had been asked if you conducted a similar study again? Are there things you would ask that weren't asked in the survey?
Yeah, great question. I had nothing to do with anything. I came in well after the fact just for data analysis. I'll have to think of it. I really haven't given it enough thought. Is anything in mind for you?
Yeah, I mean, I think some of the questions about like what does the rest of the compound do? Like, I think those are good things to think about. I think we did kind of collect data on them through the lens of our primary respondent, right? But not sort of engaging directly with the rest of the compound. But yeah, that's a good question.
I always wish you would have asked for student pledge. It's like a pretty big variation. Did you cover the models for looking at how the data map on each other and how if there's any the medium
Yeah, that was definitely a thought. When we mapped out thinking of how the mediators work, I think I started with like the categories, knowing that, well, really, I guess I started with a list of variables and then they just seem to be in these categories, and I conceptualized it in that way. And I just didn't see a ton of causal pathways going through them that at least were strong enough to like worry about, because it's probably way too complex to think about it. Like, what if one of these things is causing another, or if they're just both going up at the same time? So no, I didn't really plan on doing any more. The counterfactual framework was really cool to find. What it let us do is look at that one case in which latrine quality we thought might be upstream of latrine use, and you can't deal with that in most of the mediation methods, I believe. And that led us to this mediation package and this new, not that new, way of doing it that allows you to do that. So I'm a fan of this now because it is so flexible. And again, like I got to do ordinal regression, which is really cool, and didn't have to like squeeze variables into binary forms or do modeling that really wasn't the right thing.
I have a question first. Did you control for the water source? So kids might have getting water from different places, so that water might be contaminated, the other one might not. So did you control for that?
Yeah, so we controlled for a slew of things, including water source, but also kind of socioeconomic indicators, wealth, right? I think, child age and sex and, sort of across the board. And I didn't present, but the adjusted and unadjusted estimates were really similar to each other. And that's something that we've seen sort of like again and again in the context of this trial. We just had a large sample size and randomization worked wonders and everything was really well balanced. Mm-hmm. So in all of our analyses, sort of the adjusting did not really move the needle. The unadjusted results hold.
I have one last question from the people online. I think that's for you again. How do you standardize the evaluation time intervals within 4 months?
How do we standardize yeah. So, I mean, if you notice, we actually did not. So they're like at slightly different times, and I probably can't recite them off the top of my head. But the idea was that we wanted to catch these children at yearly intervals as they're kind of going through their development. And in Bangladesh, right, we were kind of held up. There was political unrest that was kind of stalling fieldwork. So we ended up with slightly divergent, right, sort of windows. But the idea was you want to catch them at an early age where microbiome is developing, and then you want to catch them at about like the age of 1 year, 1 year old, where they're just a bit more mobile and kind of interacting with the environment. And at the final point of in the study at about 2 years.
Any more questions? So I guess a round of applause for the speakers. Thank you everyone for participating.
Thank you.
Thank you.
Thank you.
It was really cool to see you had the Tribe 7 study in the context of that too. I was like, this is great.
I was excited.
Something we really want to look at with our study too, since they're like sister studies and pretty similar. I mean, generally, I want to see what that would be like in study as well. So.
You're in the ring.
Teşekkür ederim. Güzel. Ben Did you travel?
I went to the World Water Forum in 2009 in Istanbul. So I spent 1 week there. So I think I only learned that. It's different. I remember that. All the time.
Yeah, awesome.
At least people are not going to think that are local, but at least
Right.
Mediation is accounted for, and what's
So my
left
course is also
After the mediation, okay.
and the fact that they were all like state
Okay.
is kind of like.
Okay. I thought it was like the mediate effect of the variable and the direct effect of only that variable, and I was like, I don't get it. Okay, no, that makes sense. That makes sense. So that's okay. So I think you did a great job. I was just like, wait, I missed something. Okay, so it's the remaining, it's not even the remaining. Well, the remaining is like after the mediation.
I don't, like, I just, I missed the vote on cards, like, these days. So let me just give you my email address. Just show me a line so that we can connect. I'm happy to chat.
Done with that.
I mean, I'd be.
And which institution are you?
I'm in Morgantown.
Okay.
I'm tired of this.
Which is also fun though, because my history was like all kind of. Great to, yeah, I know, I was trying to meet you yesterday, but I wasn't able to. I was at your talk. Great to meet you finally.
Okay, terrific.
I
And
have
what was your name?
so many co-authors.
Right, okay.
Yeah.
Okay, nice to meet
Probably,
you.
I was gonna say, I don't know if we've ever
Okay,
met
great.
either, but then I was like, I think we've.
Hi, I'm just gonna come up from.
Probably. and then like-
Hi, I'm CC. Yeah, so I,
Funny how many significant that I've found that are probably like the chemicals is so big that you can.
Sorry. Good to see you. Yeah, but it's cool. I should have years that's why. And I. Oh, that's right. I wanna know how, because I've got some her and other studies. I think it does. I do, but I've not customer mediation much level now.
How's your page going?
It's good, yeah,
Well, I'm looking at the study that I'm doing has cluster.
sort of, or like
So I just will need to.
Oh, okay. So it probably is different way of expectations. So I don't know, it's probably not, you figured out that it probably won't take those.
Yeah.
But I think it was just like probably a robust.
Yeah.
Okay.
Yeah, yeah.
No, it's good. I feel like I need
Which
to.
I don't.